Assalamu alaikum. First, I'd like to thank the Society and Vertex for giving me a chance to share with you some of the experience in gene therapy and the update on the recent gene therapy updates that was presented in EHA. These are my disclosures. Let me give you an idea about the magnitude of the problem of sickle cell and thalassemia around the world. And as you can see, the distribution geographically extends from the Middle East, the Southern Europe, and North Africa, and extends to parts of Asia and Far East. This is true for thalassemia. And the disease is endemic in Africa. And again, all of these diseases are spread all over the world now. Now, for thalassemia, there are 60,000 births per year and around 300 beta globin mutation. That tells you the complexity of this disease, especially for preventing disease in couples who are interested in having a healthy child. The magnitude of sickle cell is an even larger, with 300,000 births per year. In our country, as Dr. Mohammed mentioned, we have estimated around 90,000. This is the structure of the hemoglobin. As you can see, the normal hemoglobin is formed of 2 alpha and 2 beta. And as you can see, they are symmetrically held to give them its functional aspect. Sickle cell disease and thalassemia are beta globin abnormality, when sickle cell is a functional or a qualitative problem of the hemoglobin. Under certain stresses becomes abnormal and causing all the pathology. As I mentioned, there's one amino acid substitution that under certain stresses the hemoglobin S becomes rigid when it forms polymers and leads to a rigid cell that clogs and obstructs the tiny vessels. Not only that, this is the initiation, but the red blood cells themselves, they are hemolyzed and they release the heme and the hemoglobin that consumes the nitric oxide, which is important for the integrity and stability of the endothelium, that leads to the injury of endothelium and the expression of the adhesion molecules that attracts different sort of cells that really increases the problem and leads to further inflammation that is released from the white blood cells, attracting white blood cells, platelets, and then aggravate the pathology and the vasculopathy. Now, the sickle cell disease is almost every organ in the body is affected, and it can present as clinical manifestation, but that's the only the tip of the iceberg, because other organs are involved without manifesting symptoms, in particular the brain, the kidneys, the lungs. So it leads to different pathology, and those diseases manifest later in life with life-threatening complications. As you can see, all of the organs are involved here, and some of them are life-threatening. They can manifest either in acute or in chronic basis. Beta thalassemia, you have a problem of making the beta chains, and these patients are unable to produce enough red blood cells. Therefore, they rely on blood transfusion since early infancy. As I mentioned to you, the integrity of hemoglobin is important to keep the structure functioning. But if you lose the beta globins, what will happen is that the alpha heme aggregates will precipitate in the cells and leads to red blood cell destruction and the bone marrow excessive production or an ineffective erythropoiesis that will lead to severe anemia, expansion of the medullary cavity, and the causing skeletal deformity of the skull, the face, and different bones in the body, In addition, they lead to extramedullary hematopoiesis and further on. As you can see in this picture, this child is affected in different ways due to the disease itself and due to the treatment, which is blood transfusion with iron overload. As you can see, different organs are affected. You know, the skull, the face. You can appreciate the hepatosplenomegaly, the osteoporosis. These patients have stunted growth, abnormal endocrine organs. The iron overload becomes a problem if not introduced iron chelation early in life. It will lead to deposition in very important organs like the heart, liver, and endocrine system that will lead to endocrine dysfunction, hepatic cirrhosis, and cardiac dysfunction or arrhythmias, and can be fatal. So the current therapeutic options, there are disease-modifying therapies, sickle cell disease. Of course, transfusion can be given when needed. Hydroxyurea is a very important medication, and that should be introduced early in infancy to prevent and improve the quality of life of these patients. L-glutamine and voxelotor and other FDA-approved medications that were introduced. For thalassemia, these patients rely on transfusion for survival. Therefore, early introduction of blood transfusion in addition to iron chelation is important if these patients are to have almost normal life. And we have examples of successful people who are leading normal life by taking regular transfusion and iron chelation. Sept is another medication that is approved to decrease the number of transfusion. Mitapivat is another one to reduce hemolysis. It's going to be soon a regular medication for the disease and other hemolytic diseases. The standard therapeutic curative option is the hematopoietic stem cell transplantation that Dr. Muhammad have already touched base with you, especially for hemoglobinopathies. Nowadays, we have the introduction of gene therapy that can be offered to some patients, whether it's through the gene addition or through gene editing, and I will explain that to you. So first, stem cell transplantation, best results are when this procedure is done early in life. That means usually children, preschool age is ideal. However, we have limited number of donors. Yes, in Saudi Arabia, we have much higher chances of having an identical sibling donor, but still there are a significant number, at least 40% do not have donors. And the options are either unrelated donor or haplo-identical. As Dr. Isa mentioned, that the unrelated donor are associated with severe complication, chances of GVHD, chances of rejections and failure are high, beside the complication of graft versus host disease. Haplo-identical transplant is another alternative transplant, but again, this is associated with multiple severe complications like graft rejection, reactivation of viral infection like BK virus, adenovirus, CMV, that becomes chronic and difficult to manage. Graft versus host disease is really a major challenge in this category of patients. And more seriously is the immune dysfunction that stays with the patient for a long time, manifesting as either GVHD, autoimmune phenomena, or repeated infection, and even lymphoproliferative disorders can happen from this sort of transplant. Thus, the chemotherapeutic toxic effect is well known, especially if you're using myeloablative conditioning, and the fact that the transplant is allogeneic, you have all sorts of complications related to the graft itself. Now, as Dr. Isa mentioned, the ASH recommendation is that any symptomatic patient with sickle cell can be transplanted and prevent further complication later in life. Because sickle cell disease is a progressive disease. As these patients grow, they develop organ dysfunction and they're likely to have shorter lifespan. In Saudi Arabia, it's probably more than 10,000 patients are in need for transplant if we are going to transplant them. However, we have limited capacity to accommodate these patients. Therefore, we set a criteria for severe types of patients, those who have multiple veno-occlusive diseases, recurrent acute syndrome, any sort of cerebral vasculopathy. Of course, stroke is one of them, but any vasculopathy will be an indication for transplant. Those who suffer any neurological deficit, of course. And patients with pulmonary hypertension, patients who develop sickle nephropathy are legitimate candidates for transplant. However, patients with chronic problems like allosensitization, recurrent priapism, and osteonecrosis, and the list is long, they can be included in the list to transplant. We come to the gene therapy. We know that gene therapy, if you talk about gene addition, that is to add a desired gene to the genome. This is done through lentivirus vector, that is a vehicle to deliver the genetic material down to the DNA and get the functional beta-like globin gene to function. And gene editing is through using the CRISPR-Cas technology, and basically this is like a molecular scissor where you can act and manipulate the gene that you want to do, and in practical purposes to disturb the BCL11A gene that's used in both either gene addition or editing to reverse the fetal hemoglobin repression. Alternatively, you can even correct the beta globin mutation. So if we are to select an ideal gene therapy, what are the requirements? You need high level of expression, especially if you have severe phenotype, for example, like severe beta thalassemia. You have to have controlled erythroid specific gene expression. You need to have stable long production gene product, and to avoid insertional mutagenesis or what is called off-target effects, because they can have deleterious effect. The two products that are available and FDA approved is the exa-cel, which is a gene editing that is approved to be used in patients with severe vaso-occlusive crisis in sickle cell, or transfusion-dependent beta thalassemia for patients older than 12 years old. In fact, it is the first FDA-approved therapy that is utilized for clinical basis. The other one is the beti-cel, which is gene addition that is also FDA-approved, and again, it was approved for patients with vaso-occlusive crises and patients with transfusional beta thalassemia older than 12 years. So what is gene addition? Gene addition basically is to utilize the lentivirus as a vehicle when you introduce the desired modified gene into that vehicle, and this virus will be internalized in the cells, packaged in the endosome, and the gene or the genetic material will be released once it incorporates into the genome. Mind you, the lentivirus is an RNA virus that is through the reverse transcriptase transferred to DNA that incorporates itself into the genome DNA. The idea is that if we take, for example, the BAT87Q, which is a modified beta globin, it will be inserted in a certain place in the DNA or in the gene, and with that it becomes functional, and you can trace it after engraftment, and you can see the contribution of this gene. Now it has anti-sickling effect. The amino acid change in here makes it anti-sickling, and therefore it's effective in sickle cell as well. How this procedure takes place: first, the patient will be mobilized by plexiform. The stem cells will be collected, and then these stem cells will be transduced with the desired viruses or vehicle, or what we call vector copy, that will be internalized, and then it will be tested, stored, cryopreserved, and sent to the patient. The patient, meanwhile, will be conditioned with busulfan and then injected with the product. After engraftment, the drug product or the specific gene that is desired will be traced, and you will know how much it contributes to the hemoglobin. This is a study that was done by Locatelli and was released on 22 patients on non-transfusional beta thalassemia and 2 patients who have severe transfusion dependent. As you can see, the contribution of the gene has been significant, as if the total hemoglobin was 12.6, and the contribution of the inserted modified gene is 10.6. And as you can see on follow-up, this blue bar indicates that they are transfusion-free. 2 patients, unfortunately, did not do well, and these happen to be the severe transfusion-dependent type. In sickle cell, similarly, you can see that the last 2 years they have multiple vaso-occlusive crises after the infusion of the drug product. None of them developed vaso-occlusive crisis on follow-up. The contribution of this gene is around 45% in all the group, and again, this happened to be protective to these patients. Now we come to the gene editing. The idea of gene editing to allow very precise changes in the DNA. The genetic material can be either disrupted, deleted, corrected, or inserted at precise location, a specific location in the genome. There are several clinical trials utilizing the gene editing. I'm not going to go through them, but thanks to these 2 scientists, Dr. Carpentier and Dr. Dudna, they won the Nobel Prize in 2020 in chemistry for their discovery, the CRISPR-Cas9. Interestingly, their observation on how the bacteria defends itself against viruses was through this mechanism, and they learned that and applied it on humans and clinical trials. The idea of CRISPR-Cas in clinical practice is that CRISPR-Cas consists of Cas enzyme and single guided RNA. Now, the Cas and single guided RNA form a complex and function as a unit to edit the DNA only when it reaches specific location, because they have specific codons that comes to that specific point. That makes the precision. During the repair of the edited DNA, a change in the target DNA sequence is introduced. And the change in the target DNA sequence inactivates the gene or alters its function. Now, there are 2 ways of repair here, what we call directed repair, when you have the mutated gene altered and made dysfunctional, and then an introduction of a DNA template that fixes the mutation. With that, they fix the abnormality. The non-directed repair method is that if we take, for example, sickle cell disease, as you can see, the hemoglobin clumping, what you do is to disrupt the BCL11A gene and leave the gene to heal spontaneously and naturally. With that, you arrest or you repress the BCL11 and enhance the production of gamma globulin. And this is the idea that is used nowadays in gene editing to treat thalassemia and sickle cell. Now we come to the update and the Climb 121 that was reported last in EHA. I have explained the idea of the BCL11A. Basically, the function of BCL11A is to suppress the gamma globulin, and this is a natural mechanism that happens in utero and early in the first few months of life. So once this gene becomes active, then you have hemoglobin F, or the gamma globin is suppressed. So this technique disrupts the BCL11, as I showed you, and will allow higher levels of gamma globin and higher level of hemoglobin F. What is the significance of high hemoglobin F? Is that high hemoglobin F is protective, and with levels of more than 30 or 40, you are resembling a phenomenon that we see in hereditary persistent fetal hemoglobin, and that is seen when the patients with sickle cell and have high hemoglobin F, they're asymptomatic. So with that, this proved to be effective in these patients. Similarly to what I mentioned to you, the way of collecting the stem cell and treating them here in the how to introduce the CRISPR-Cas is through electroporation to create an electric gradient that internalize these products in the cells. And again, similarly, they'll be checking the quality and then frozen and sent to the patient. The same thing, we're using busulfan for conditioning the patient and then follow up on the product. And the design of patients who, for patient with sickle cell, 46 patients were infused with the product. Their ages are 12 to 35 years, and they have all a history of severe VOC, more than 2 per year in the last 2 years. Now, the primary endpoint or primary efficacy endpoint is the patient to have free severe VOC period of more than 12 months. The secondary efficacy point of these patients to have non-inpatient hospitalization. So evaluable patients out of the 46, we have 39 patients. Around 30% of them are adolescent and the rest are adults. The genotype, mostly severe genotype, either SS or S beta 0. They have co-inheritance of alpha globin gene in around 30%. The VOC episodes average of 4 per year, and the hospitalization around 2.6 per year. Now, they required an average of 2 collections per patients, and the average cell dose of stem cell is 4.7 million per kilo, and the follow-up was up till average of around 28 months. The time of engraftment is 27 days for neutrophils, and platelet engraftment of 34 days. Time from hospitalization to discharge is around 1 month, and this is the demonstration of the patients. As you can see, these episodes of painful episodes in these 39 patients evaluable, and then you can see the washout period of 60 days, and then the majority of them did not have any vaso-occlusive disease, 36 of 39. The blue diamonds here are patients who developed either infections or patients who had chronic pains that come to get some opioids and leave because of their chronic pain. One patient had the bone marrow procedure and developed a painful episode. So these are the complications that were seen, and unfortunately one of the patients developed COVID and died following engraftment. This is the days that were free of inpatient hospitalization, and again, as you can see, this patient who had the bone marrow biopsy, and this patient who had parvovirus infection. Now, the hemoglobin F percentage out of the total hemoglobin was almost 40 to 50%, almost 40%, and that proved to be very effective to keep patients free of symptoms. This is the total amount of hemoglobin, which is close to 13 in both adults and adolescents, and this is the contribution of the hemoglobin F that you can see in both groups. It's very important to have the quality of hemoglobin F in these patients. As you can see, all these patients have pan-cellular distribution. This shows you the qualitative effect of the hemoglobin F that plateaued more than 90% and remained throughout the follow-up period. This is the edited BCL-A alleles, and they were traced and followed both in bone marrow and peripheral blood. As you can see in the green line, these are all have achieved the end point, the primary end point. Those who had blue lines did not achieve it. Yes, they have good allele editing, but they remained symptomatic, and some of the red is still not achieved the end point yet. In peripheral blood, similarly, as you can see, significant maintained BCL editing follow-up. Now, markers of hemolysis significantly dropped in the lactate dehydrogenase, the haptoglobin dropped, and the retic count, in addition to bilirubin. What are the serious or the side effects that we're seeing? It's combination, some of them due to the conditioning by busulfan, and some of them due to XSL. As you can see, the serious side effects to XSL were not encountered. The one patient who died of COVID, and this thought to be not contributory by the treatment. And none of the patients developed malignancy. The other busulfan toxicity, as you can see here, stomatitis, nausea, abdominal pain, etc. Now, quality of life, and as is patient-reported outcome, was checked by several scales. Some of them pain scales, some of them are quality of life scale. And as you can see, all of them demonstrated improvement after the infusion. The pain scale also showed improvement in these patients. So it's all a positive after the infusion. Now, what about the beta thalassemia? The beta thalassemia, again, the technique is the same. There are 56 patients were infused. All of them were beta 0, almost all of them are beta 0. And the end point, the primary efficacy point is to achieve 12 months of non-transfusion or transfusion-independent period. Again, similar to the other patients, 1/3 of the patients were adolescents and the rest were adults. The genotype is most of them, almost 60% of them are the severe genotype disease, and there are 40% non-beta 0, beta 0. The infusion, the mobilization, one mobilization was required. The cell dose was 8.4 million, and the duration of study was 32 days, 32 months. The neutrophil engraftment was 29, and the platelet engraftment was 43. It took around 40 days from admission to discharge. And as you can see here, patients before the infusion and after the infusion. And as you can see, almost all of them except these two patients extended from the previous study, and they started to achieve some transfusion independence. So 49 out of 52 evaluable patients achieved the transfusion independent period. This is again the contribution of the hemoglobin. Almost 90% of the hemoglobin was contributed by the hemoglobin F, as you can see, and the level of hemoglobin again was around 13 in these patients, both adolescents and adults. The pan-cellular distribution was same as what was seen in sickle cell, which is really encouraging, and it remained in the straight line. This is the BCL edited alleles, and you can see it's in the bone marrow reaching 90%, and also in the peripheral blood is continuing. Serum ferritin showed significant drop. These patients, after the treatment with the gene, they required chelation therapy either by phlebotomy or iron chelation medication. In fact, 40% of them were able to stop iron chelation after some time. What are the serious side effects? Again, due to XSL, there are a couple of patients who developed HLH manifestation and idiopathic pneumonic syndrome. And another one developed delayed engraftment, thought to be due to XSL, but all of them resolved. On the other hand, the busulfan toxicity was seen in 7 patients that were treated with defibrotide and also deoxycholic acid, and all of them recovered. These are the side effects of conditioning with busulfan. The quality of life, again, similar to what we've seen in sickle cell, all of them indicate positive effect and improved quality of life. And as you can see, all of them were positive. So, in conclusion, for sickle cell, 92% achieved primary endpoint and were free of vaso-occlusive disease for 12 or more months. The mean duration of vaso-occlusive crisis were around 28 months, with the longest follow-up of up to 4.8 years. 97% achieved secondary endpoint, free from hospitalization, with a mean duration hospitalization-free period of 28 months. The durable increase in hemoglobin F more than 40% with pan-cellular distribution resulted in a total hemoglobin levels normal or near normal levels throughout the duration of the study. Stable allelic editing in bone marrow and peripheral blood was demonstrated in the long-term stem cell evaluation. Clinical, meaningful, and durable improvement in hemolysis measurements, quality of life was seen. There were no serious side effects related to XSL. Safety profile is consistent with myeloablative busulfan conditioning. So XSL has the potential to provide a one-time functional cure for patients with sickle cell disease. For transfusion-dependent thalassemia, 94% achieved the primary endpoint of having independence transfusion for 12 months or more, and the longest follow-up in this group was up to 5 years. The stable allelic editing of bone marrow and peripheral blood was demonstrated, durable editing throughout the study. Clinical meaningful improvement in the measurements of iron overload and quality of life were observed. Serious adverse reaction attributed to XSL occurred in 2 patients and they resolved. The safety profile consistent with myeloablative busulfan conditioning and autologous stem cell transplant. So XSL has the potential to provide a one-time functional cure to patients with transfusion-dependent thalassemia and sickle cell disease. Thank you.